Hi friends, welcome to my channel Ophthalmology Academy. This time we're going to discuss a very important topic, that is the watering in neonates, watering in babies, also called as congenital nasolacrimal duct obstruction. We'll be covering it under certain headings. But first, we need to understand the basics of the lacrimal tear flow drainage. This is very important to understand the watering in babies. Tear comes out of the lacrimal gland here. It flows into the conjunctival sac and then transmits through these red lines. These are actually canaliculi. This is the upper canaliculus and this is the lower canaliculus. So it drains from the conjunctival sac into those canaliculi and into this upper and lower canaliculus. It directly drains into the lacrimal sac. This is the lacrimal sac area. This is the lacrimal sac, and from here from this lacrimal sac it drains the tears downwards into the nose in the inferior meatus. This tube structure is called as nasolacrimal duct. This tube-like structure takes tears from the lacrimal sac down into the nose. A very important structure concerned the watering babies. There is a fold of mucosa. There is a valve-like mucosal structure called as valve of Hassner, which is present in the lower end of the nasolacrimal duct here. Now coming to the pathogenesis of the watering in babies or the congenital nasolacrimal duct. This nasolacrimal duct develops from a cord of cells. The cord of cells is just like a solid column, and it gets canalized during the fetal phase of life. However, this lower part it canalizes, that is, it gets converted into tube at last. Sometimes it gets converted into tube even after birth. In some babies, this lower part of the nasolacrimal duct doesn't canalize or canalizes later. This manifests in the blockade of the tears, so that tear stagnation occurs and we see watering in the eyes. The most common cause of watering in children is this mechanism. However, there can be certain other causes, like there may be total non-canalization of the nasolacrimal duct. That's also an important. Sometimes there are epithelial debris or amniotic fluid which has blocked this lacrimal sac area, and in certain cases, especially patients with craniosynostosis, Down syndrome or golden hair syndrome, there are bony deformities which prevent the canalization of this nasolacrimal duct so that the tears do not flow from the lacrimal gland into lacrimal sac into the nose. Incidence is usually it's seen in 20% of the babies, full-term babies. However, the good thing is that it spontaneously regresses. That is, the lower end of the nasolacrimal duct spontaneously canalizes within the first year. So that means in 20% of the children it is present, but out of those 20%, 90% of the 90 to 95% of the children have spontaneous regression. Signs are there will be epiphora, that's the tearing in one or both eyes, and there will be recurrent pink eye, that is recurrent conjunctivitis, and due to the continuous watering the periocular skin may be chafed because of the tears. These signs and symptoms usually worsen with upper respiratory tract infection, and if we press on the lacrimal sac area, there may be reflex of a mucoid or mucopurulent material from the punctum. Sometimes because of the conjunctivitis, these children can have matting of eyelashes also. Usually this condition is easy to diagnose, but there can be few differential diagnosis of this condition, that is we have to differentiate it from certain pediatric conditions. One of the most important is the congenital glaucoma. Congenital glaucoma presents with the triad of the photophobia, watering of eyes, and the spasm of the eyelids. Then another important differential diagnosis will be a chronic conjunctivitis, that is there is persistent epiphora and discharge, not due to the congenital nasolacrimal duct obstruction, but it is because of the infection of the conjunctiva per se, especially seen by the gonococcal infections which present in the neonatal age group, although rare now. And the third differential diagnosis will be a punctal atresia, a simple condition. As I already said, that the congenital nasolacrimal duct obstruction regresses spontaneously in 90% of the patients, so most of the patients are put on a conservative treatment. This conservative treatment consists of sac massage, there is the massaging at the lacrimal sac area, and if there is associated discharge, we can also prescribe antibiotic drops. But the most important thing is to teach the parents to do sac massaging. There is a proper technique for sac massaging, which I am going to show you. First, you have to clean your index finger and then press here at the junction of the two canaliculus. By applying pressure on this spot, then go downwards. Start from the common canaliculus and then go downwards, and this massaging is done usually 20 to 40 times depending on the severity of the watering of eyes. And the mechanism of this is that it generates hydrostatic pressure within the lacrimal sac, which helps in opening the valve of Hessner abnormality. In case the patient is not relieved of watering for 6 to 12 months, and another method of treatment is probing. Usually there is actually different surgeons do it at different times. If usually it's delayed till 12 months because the baby is more mature, and this procedure has to be done under general anesthesia most of the times. However, those surgeons who can afford to do it under sedation or in their office, they can go at an early stage. They can do it at an early stage as early as 6 months. In this technique of probing, the instrument which I have shown is a lacrimal probe. This is passed through the superior canaliculus into the lacrimal sac, and then as it reaches the lacrimal sac, it is tilted 90 degrees downwards towards the nose, and a definite pop is felt as the valve of Hessner is perforated. This might lead to minimal bleeding, and after doing probing, the patency is confirmed with a fluorescein injection through the upper canaliculus. The important thing here is that this probing can cause iatrogenic damage to the canaliculus. That is why the lower canaliculus is usually spared and probing is done through the upper canaliculus. As we know that lower canaliculus drains about 70 to 80% of the tears, so even if the superior canaliculus is damaged during probing, this lower canaliculus will still be functioning. Probing can be repeated after 6 weeks in case it fails. Few other techniques to address this congenital nasolacrimal duct is balloon nasolacrimal duct dilation and silicone tube intubation, not used very oftenly. And last of all, in case no measure addresses this issue, then we can go for DCR surgery, that is dacrocystorhinostomy surgery. But it's delayed till age of 4 or 5 years. Although the conventional external DCR surgery gives good results in children, but there is always a fear of the cosmetic scar, cosmetically intolerant scar on the face, as well as injury to the medial canthus and the nasal bones. So some surgeons prefer endoscopic DCR in these patients. Overall, the results of congenital nasolacrimal duct is very good. The prognosis is very good. However, you may have to undergo multiple procedures, but overall the watering is relieved. Thank you so much for your patient hearing. Like and subscribe to my channel for getting more and newer updates, newer videos regarding ophthalmology.